Well, good evening. Thank you for joining me here tonight. I'm going to be speaking with you guys about non-pharmacologic approaches to pain management tonight. But before I get onto that topic, I want to put pain in a little bit of context, give you a little bit of a better understanding of the incidence of pain in this country. So in 2011, the Institutes of Medicine commissioned a report to look at the incidence of pain in this country, better understand the prevalence, the cost of pain in the United States. And the report produced some pretty staggering figures. They found is that chronic pain affects over 100 million U.S. adults. This is more than the total number of people affected by heart disease, cancer, and diabetes combined. Right, so a pretty large figure. But what's even more staggering is the estimated cost of chronic pain. They estimate that pain has a cost of $500 to $600 billion in medical treatment and lost productivity. Right, so it's a pretty significant cost, pretty significant figures. But what's most impressive about the IOM report is that it's actually an underestimate of the incidence of pain in this country. Why do you think that it might be an underestimate? If you look at what's written up there. Yeah.
How do you define pain?
That could be part of it, by how you define pain. But there's one large population that's missing here, which is children. Right? This is 100 million U.S. adults. So when we add in the number of pediatric patients as well, you can imagine that this number just gets that much higher. Right? So pain is clearly a very important thing that we need to address, that we need to look into a bit more, specifically how to manage pain, how to treat pain. So pain itself, does pain serve any purpose or function? A lot of you guys nodding your head. What purpose or function does pain serve?
It brings attention to an area of your body that you need to be paying particular care for.
Okay, so it brings your body's awareness to a particular area that you need to care for. What other function does it serve? Yes, sir?
Keep your finger off a hot stove.
Keep your finger off a hot stove, right? So it's a warning sign to you, right? So in its most primitive form, that's one of the functions of pain, is to serve as a warning sign that there's some sort of active damage occurring to the body or some sort of imminent damage, and we need to do something right now to prevent more harm from occurring to the body, right? So using the example I was just given, a hot stove, right? If I'm cooking on a stove, the first thing you learn about me tonight is I'm a liar because I never cook on a stove. But hypothetically speaking, if I was in the kitchen, if my hand touches a hot burner, I'm going to feel pain. Right? And that pain is going to be a warning sign to move my hand away from the burner to prevent more damage from occurring. Right? If I didn't feel that pain, and if my hand just stayed on the burner, what would end up happening to my hand? It would burn, right? There would be some pretty significant damage, but if my hand persisted to stay there, the damage would get worse and worse, right? So the pain served as a warning sign to alert me of some sort of damage and that I need to do something to prevent more harm from occurring. But is that true of all pain? Is all pain a warning sign that there's some sort of active damage occurring in the body and we need to do something right now to prevent more harm? Right. See, a lot of you guys shaking your head saying no, and you just saved yourself an extra hour of my presentation, right? So this isn't true of all pain, right? This is where we start to get to the two very broad categories of pain, acute pain and chronic pain. In the case of acute pain, the pain that we experience, the hurt that we experience, is a sign of some sort of active damage occurring in the body. Right? So the hurt is associated with harm. In that example of my hand touching the stove, I feel pain, there is harm occurring in the body. Right? So avoiding the pain, doing something to avoid that pain, moving my hand away from the burner, it does serve an adaptive purpose. In the case of chronic pain, though, the pain is real. Right? The hurt that a person is experiencing is very real, but it's not a sign of active damage occurring in the body at that immediate time. Right? So for example, some of you sitting in the audience, you may be experiencing pain in a part of your body right now as you listen to me, but that doesn't mean that your body's in immediate harm's way and that you need to do something right now to prevent more harm from occurring in the body, right? And this is one of the biggest differences, but one of the most difficult differences to wrap our minds around in the case of chronic pain is recognizing that even though this pain signal is there, it's not a sign of some sort of active damage occurring in the body, right? And one way that we can conceptualize chronic pain, once all the medical workups have been completed to ensure that it's not a sign of some sort of active damage occurring in the body, is we can think of it as being like a false alarm in the body. So if this group of us were to go outside in the parking lot, and if we were to stand around a car, nobody touches the car, there's no vibrations to set it off, and if the alarm starts going off, we're not going to try to convince each other that we're just imagining the alarm going off, right? We can hear it, we can see the lights flashing, but we also know that it's a false alarm. There's no threat to that car, but the alarm is still being triggered. And essentially, that's what's happening in the case of chronic pain. The pain is the alarm, but there's no harm occurring in the body. Right? So it's essentially a false alarm going off within the body, alerting you to some damage that's not actively occurring. The damage may have occurred. The pain may be the result of some sort of injury process that has since healed, but the pain is still lingering. It may be part of an ongoing degenerative condition, things like arthritis, things like a degenerative disc disease, where, again, the pain is real, but it's not a sign of imminent damage occurring in the body, even if there's some sort of a progressive condition that's occurring. Right? And this is the case, again, in chronic benign pain. So this is separate from like cancer pain and things along those lines. But there's more differences than just this. The causes. We know with acute pain, there's oftentimes a very clear pathway, a very clear understanding of what caused the pain to come about. And oftentimes, not always, but more often than not, there's a single cause for that pain, right? Using the same example of the hand touching the burner. If my hand is touching the stove, I'm going to feel pain, but we know exactly where that's coming from. It's coming from my hand touching a hot burner. But in the case of chronic pain, it's a little bit different, right? There are a lot of unknowns with chronic pain. We may be able to identify that the pain started with the particular injury, but we can't explain why it is that two people who have the same injury or the same problem in their body, one person goes on to develop chronic pain and the other person doesn't, right? Science hasn't caught up with that yet. We don't understand why that is. Also in the case of chronic pain, even if we can give it a name, that still doesn't mean that we understand exactly why that pain is persisting, why that false alarm is going off. So we may call it fibromyalgia, we may call it myofascial pain, neuropathic pain. These diagnoses may be present, but that doesn't mean that we understand, again, why this chronic condition is there. But this has significant implications for treatment. In the case of acute pain, there's a fixed endpoint, right? Let's use a different example. Let's say that I'm running down the hall and I slip and I twist my ankle, fracture my ankle rather, right? It's got a clear pathway. The hurt that I'm experiencing is associated with harm, right? I've got a fractured ankle. There's a clear pathway for that. I slipped and I fell. But I also know that there's going to be a fixed endpoint to that. Right? If I fractured my ankle, I go to my doctor's office. What types of things might they tell me that I need to do for that? I may need to have surgery depending on the fracture. They'll tell me to stay off of it, right? Immobilization. Immobilization is going to be essential to my recovery, right? If I'm stubborn and if I say, well, I'm just going to walk and do my regular activities on this fractured ankle, what's going to end up happening to my injury? It's going to get worse, right? So I have to make sure that I'm immobilized, and that's an essential part for recovery. Also, my provider might give me medications. I might be given short-acting like opiate medications, things like codeine, hydrocodone, oxycodone. These are powerful agents, but they also have a lot of side effects that come with them. You know, a lot of these opiate medications, they can cause cognitive cloudiness, where we have difficulty thinking, we feel like we're in a haze. It can affect memory, attention, concentration. These medications, opiate medications, can affect our GI system. They can cause changes in testosterone levels. It can affect mood states. So these medications are certainly not benign substances. They have a wide range of effects on the body. But I've got a fixed endpoint with my pain, right? And I'm thinking to myself, what's the cost? What's the benefit of this? Well, the cost is I may be a little bit hazy for a few weeks, but I know this is going to end and it's going to give me sufficient relief so that my body can heal, right? So my provider and I may decide, okay, we'll do this for X amount of time and then I'm done with it, right? In the case of chronic pain, though, it's a pretty different situation. For one thing, we don't have a fixed endpoint with chronic pain. Right? We can't tell you that if you do all the things that we tell you to do, or if you have this particular surgery, or if you have this injection, your pain is going to disappear and that it's never going to be there again. Right? So there's no fixed endpoint, but this has direct implications for how we treat it. If I've got a condition for which there's no fixed endpoint, let's say that I've hurt my low back, right? If I tell myself, you know what, it hurts to stand, it hurts to walk, but if I'm sitting in my recliner at home, I'm actually pretty comfortable. I'm not loading on my spine. I can work on my computer from my laptop or from my recliner. I can watch TV. I can eat my meals. I might feel like, okay, this is good. I'll just immobilize. If I do that for several weeks on end, right, where I'm just mostly sitting in my recliner doing my work, muscles are going to start to weaken in my body. I'm going to start to have atrophy of my muscles because I'm not using them, right? One day I'm going to get tired. I'm going to say, you know what, I'm fed up of just sitting here in my recliner. I want to get up and do something. And maybe something as simple as walking my dog or going to the grocery store. But what I might find is that my whole body starts to hurt as I try to move around. And it's not that my pain condition is migrated from my back to other parts of my body, but the deconditioning process is set in. And that immobilization has caused atrophy of my muscles. So disuse of my body, in the case of chronic pain, immobilization, will actually worsen a chronic pain condition, right? Does that mean that we need to go in the other extreme and we should be overactive with chronic pain? No, right? Overactivity will also worsen a chronic pain condition. So that's one of the really challenging things with chronic pain, is that we have to have a delicate balance between doing too much and doing too little, and either one of those extremes is going to be an unhealthy place for us, right? And the last thing involves medications. Because we're dealing with a situation that doesn't have a fixed endpoint, all of a sudden we have to take a closer look at the cost-benefit of these different medications. We can start to have a lot of problems that develop with the medications. One thing is that we can start to develop tolerance to the medication, where we need more and more of the drug to achieve the same effect. Tolerance isn't the same thing as addiction. It's a completely separate thing. And we can develop tolerance to virtually any type of substance. It doesn't have to be a medication or a scary substance. We can develop tolerance to coffee, for example. Right? If you wake up every day and you have a cup of coffee to get you started, you may find after a few months that, you know what, just 1 cup isn't really enough. I need to have 2 cups, and that's what really gets me energized. After a while, 2 cups really isn't enough. You need to have 3 cups, and that's what kind of gets you perked up. And after a while, you're drinking a pot of coffee because that's about what it takes, right? And what's happened is you've developed tolerance, where you need more of that caffeine to achieve that same effect. Well, we can get that same type of tolerance with these pain medications. But the problem is as we start to develop tolerance to these pain medications, I mentioned all those side effects that can come with these drugs, right? We can have GI issues, it can affect mood states, it can affect our mental functioning. Well, if we start taking more and more of these medications, then the side effects oftentimes can start to multiply. Where something that caused just a little bit of haziness, now we have a hard time getting full sentences together. Our speech becomes a little bit slower. We have a harder time maintaining alertness, right? So the side effects become more problematic. And we have to kind of look at that cost-benefit analysis again and saying, is this really worth it to have this degree of impairment, even though I may be getting some degree of pain relief with these drugs? Also with the medications, we have to have caution with the polypharmacy that can start to happen. And what that is where we start taking a ton of different medications. You know, I've seen countless numbers of patients that come through our hospital program or outpatient center where before they had their pain condition, they never really took any medications. They would sparingly take even over-the-counter things like Tylenol or Advil. But after their pain condition is set in, they started taking perhaps opiate medications. After a while, they developed tolerance. They had to have escalating doses of the drug. But then the side effects would start to be bothersome. So they may get sedated. So they may start getting prescribed a stimulant medication to combat the sedation from their opiate medications. But then that stimulant starts to get in the way of sleep at night. So they start taking a sleeping pill to help them sleep at night. And before long, they're starting taking medications to treat their side effects. And those meds have side effects, so they may take drugs to treat the side effects of their medications. And this person who never really took any drugs has now got a page or a page and a half of medications they're taking. Right? We've seen folks whose medication bills are $7,500 to $10,000 a month just in medications. And these are some of the folks who've never really taken meds before. And these aren't addicts per se, but people that have developed a high level of reliance on these medications to help manage their pain. So that doesn't mean, though, that there's no role for medication in pain. There absolutely is, but we just have to have a lot more caution with the prescribing of these medications. Make sure that the benefits that somebody gets aren't outweighed by the cost. And that's something that a dialogue that a person has with their provider to make sure that they're in a healthier side of that balance. So if we look at these two things, acute and chronic pain, they're two completely separate beasts, right? If you've got a chronic pain condition and we try to treat it using an acute modality, we're not going to get too terribly far, right? What that's going to look like is constantly trying different medications, constantly trying different injections, hoping that maybe the 160th time that we do this, we're going to have a different outcome, right? But the reality is that's not likely going to be the case, given the fact that we're dealing with a chronic condition that's not going to have a fixed endpoint, right? But even worse, my personal perception is that continuing to try to use an acute modality with a chronic pain condition is a disservice to the patient. Because naturally what's going to happen is the patient's going to get their hopes up every time they hear that there could be a procedure, there could be a medication that could result in great benefit for the person, right? You know, let's say that you come into a clinic and you meet with Dr. Smith, and Dr. Smith says, okay, I see you've had low back pain for a period of time. I also see you've been working with Dr. Jones. Has Dr. Jones ever done a facet block on you? You're like, a what? A facet block? No, I don't think he's ever done that. Really? I'm surprised. I've had great luck with doing facet blocks, and I've seen people that have your kind of pain, they do remarkably well after this. We'll set you up for one of these blocks. You're naturally going to get excited. You're going to think, why did it take me so long to get to this clinic? You know, this guy has the answers. He clearly knows what he's talking about. You do that procedure, Again, dealing with the chronic pain condition, not an acute pain condition, you do that procedure after living with pain for so many years, after having so many other injections or surgeries, and it's not going to be that magic bullet. It's not going to be the thing that fixes your condition and makes it all go away. To the provider you saw, they're genuinely sorry. They're like, I'm so sorry. I thought that would work for you, but that's, pretty much all I had in my arsenal, so I'm sorry. And so they go on about their day. They see the next person, but you're left suffering still, right? And beyond that, you've had an emotional setback because you got your hopes up naturally that this is going to be something that will produce some sort of a different outcome. So not only is it not necessarily going to yield the outcomes we want, my perception is that if we keep treating chronic pain using acute modalities, we're actually setting people back, right? So we have to take a different approach to chronic pain. And the approach that we take is a management approach, right? This management approach is the same approach that we take with any kind of chronic health condition that doesn't have a cure. Diabetes, heart disease, asthma, these are all chronic health conditions that we don't have a fix for, right? Diabetes is one of the most common examples, one of the most common chronic conditions that are out there. What are some types that, well, first of all, do we have a surgery or a pill that cures people of diabetes? No, we don't have one, right? But just because a person gets diagnosed with diabetes doesn't mean it's game over, right? A person with diabetes can still have a very high quality life. What are some of the types of things that a diabetic might have to do to manage their condition? Change their diet, right? So they'll have to regulate their diet. What else?
Take insulin.
Yeah, if they're insulin dependent, they'll have to take insulin. If they're medication dependent, take their medications. What else? Regular exercise, right? Check their blood sugars. They'll have to monitor wounds, make sure that they're healing properly. And if a diabetic does these things, again, they're not cured of their condition, but the condition is managed, and they still have that space to have good quality of life, right? What we know about pain is that there's a similar paradigm that we follow with chronic pain management, that we need to have a constellation of different things working together to help keep that condition optimized. And the first one is just that, medical optimization. And what this means is taking a look at all aspects of a person's medical care and making sure that it's optimized. One of the first things we do with chronic pain is we need to make sure that it is chronic pain, that it's not some sort of acute process. And so usually before anything is labeled as being something that's chronic pain, people have had extensive workups to make sure that there's no other sinister pathology going on. But we also need to make sure that there's not a role for procedures. There may be roles for implantable therapies like spinal cord stimulators, intrathecal pumps. There may be a role for injection therapies. There may be a role for surgery. All those things may be a part of a person's care. But we need to make sure that that's being addressed. And that's all the medical pieces. And of course, the medication side of things, making sure that people are on the most appropriate medication for their condition at the most appropriate level. A lot of times we see people that are over-medicated, under-medicated, or not on the most appropriate medication for their condition. And so all these things that I just mentioned fall under the umbrella of medical optimization. There's also physical reconditioning. And this is just what it sounds like it is, taking a look at all aspects of the physical functioning and making sure that our body is as conditioned as possible. When we have a chronic pain condition, there's a natural tendency to guard the part of the body that's affected by pain, right? Let's say that I've injured the right side of my low back. What I'm going to have a tendency to do is try to protect that part of my body as best as possible. When I transition from a chair to standing up, when I'm getting in and out of bed, when I'm walking, I'm going to try to minimize my use of that part of my body. Well, what can happen is I can start to cause atrophy of those muscles that I'm trying to protect, which can worsen the condition, but I may also start to cause overuse problems with the way I'm compensating with other parts of my body, right? So physical reconditioning is taking a look at the parts of our body affected by chronic pain and making sure that they're kept as toned as possible, making sure that any kind of compensation that we're using isn't causing more problems for us further down the line. And this is usually done with a physical therapist or some sort of a rehab provider. But then the last piece is behavioral and lifestyle modification. And this is basically taking a look at everything else. We know that with chronic pain, regardless of what the core cause of the pain is, regardless of what the pain diagnosis is, we know that different substances, different stressors, different emotional states can all affect the pain that a person has. And helping people become more aware of what these factors are, how they influence pain, is a big part of the behavioral and lifestyle modification piece. Right? And this is typically what a pain psychologist would focus on in a person's care. So optimum pain management is a combination of all of these factors working together. Right? Oftentimes what we find is that people pigeonhole themselves in just one of these categories, and that's not going to be too terribly effective, right? That's just like a diabetic. If a diabetic says, you know what, I don't really like this diet. Splenda doesn't really taste like sugar, and so I don't really want to adhere to this. And I don't like needles, so I'm not going to check my blood sugars. But you know what? I believe in exercise. I'll exercise and I'll take my medications. And if I do those two things, I should be okay. Is that true? If a diabetic kind of picks and chooses what they want to do in their care, will they have the same outcomes? No, right? Their condition is going to worsen. And it's the same thing in the case of chronic pain, that unfortunately we can't pick and choose which of these things we want to do. We can't say, no, I really don't care too much for that behavioral piece, and I really hate physical therapy. It tends to make me feel worse. I'm just going to try to focus on the medical piece, right? If I just do that, if I just find the right doctor, then I'm going to be in a better space. If we do that, then we're selling ourselves short. It would really be no different than the diabetic that chooses to focus on just one aspect of their care. So we really need to have a balance of all of these different pieces working together. And that's called an interdisciplinary approach to pain management, where you've got these different disciplines working together for a common cause of helping to improve quality of life, helping people learn how to live with their chronic pain condition. Now, oftentimes, when people hear me say that, learn to live with the chronic pain condition, it's not uncommon for me to see people cringe a little bit. You know, what do you mean, live with chronic pain? That sounds horrible. So let's say that this square represents your life, right? If you're traveling somewhere, if you're flying somewhere, if you're going to a reunion, you meet up with people you haven't seen in a while, and if somebody asks you about your life, what kinds of things might you talk about? Hobbies. What else? Work. Family, hobbies, leisure activities, right? These are the things that fill our life, the space of our life. These are the things that give us quality of life, right? Well, one day a pain condition sets in, right? It may start off as just kind of a blot here, but you still have plenty of space in your life for other things that you do, but this pain, it's kind of taken central focus, right? Over the course of time, as a pain condition goes from something acute to chronic, so when it fails to respond to the initial medical treatments and it evolves into a chronic condition, it starts to affect all these other areas of your life. Right? Activity levels can start to decrease because it's painful to start to do things. We may have increased emotional distress, things like depression, anxiety, anger, frustration. And it may not be clinical depression or clinical anxiety, but just these emotions as we define them in the dictionary. Sleep disturbances can come about. The sleep disturbance may be related to pain. It may be related to the medications we're taking to pain. We can have an increased number of doctor office visits. It's not uncommon for us to have a lot of our folks tell us that the biggest form of social interaction they have is when they come into our clinic, right? And I know some of the people I work with, they're not the most pleasant people to be around, right? Interpersonal problems can start to develop, where naturally if people are pulling away from things that give them pleasure, if they're not able to work, if they're not able to have the same quality of interpersonal relationships, problems can start to develop in those relationships. And of course the physical deconditioning, where the body's no longer as strong as it was. So all of a sudden this pain, which started off as just a blot, it's radiated out like a crack on a windshield, and it's overshadowed all the other aspects of the person's life. And so there's no more space for those things that give it meaning. And that's why it's not uncommon when we talk with people who have chronic pain, they're no longer talking about their hobbies, their family, their leisure activities, but they're talking about their medications, their doctor office visits, the procedure, the new person they met who may have a surgery or has some sort of a concoction that they think will work for them, right? It's understandable why that shift happens because the pain starts to overshadow everything else. So helping people learn to live with pain is addressing all of these different factors. It's not fixing the pain, but it's helping people learn how they can decentralize the role of pain in their life, addressing the emotional distress, the physical deconditioning, so that people can have that quality of life again, right? So how does this happen? Well, we teach a lot of these things in outpatient classes. You know, in our Stanford Outpatient Center, we have outpatient classes that meet once a week over a 9-week period to help people learn some of the different behavioral strategies and techniques that we can use to help improve quality of life and get people more active. I'm going to go over a couple of these things in the second half of the presentation. People can have individual sessions. So outside of the classes, people can meet individually with the pain psychologist and work one-on-one to learn how to fine-tune some of these things and apply them in their life. We have an inpatient hospital program. Stanford's got one of, I think, only 2 academic inpatient pain programs in the country. I think Hopkins has the only other one. But in this program, we take folks who are really very compromised because of their pain condition. Oftentimes they have high levels of pain, a high number of psychiatric comorbidities, high levels of medication use, and very low levels of activity. And what we try to do is basically reset them, right? We clean up the medication regimen, teach them these different behavioral approaches to pain management, have them work with physical therapy, occupational therapy, to basically give them a different pathway to how to manage their pain. They're not cured when they leave the program, but hopefully they'll leave the program with a better sense of a trajectory of how to manage their pain condition on an outpatient basis. What I want to do is go over some of the different pieces that we talk about in these non-pharmacological approaches to pain, in these pain coping skills classes. So oftentimes we give people an overview of pain, very similar to what I just went over with you guys, helping people better understand the difference between acute and chronic pain. Because it's really surprising that even if people have had chronic pain for a long period of time, they're still used to thinking about it from an acute paradigm. And that oftentimes gets reinforced even by our medical system that constantly tries to do more procedures or try different medications or the latest and greatest thing. So just having that overview of pain is an important part to help people understand why a different approach is necessary. Help people learn pacing of activities. We talked about how immobilization is not healthy, but overactivity is not good either. So how do you navigate that fine line between doing too much and too little? That's part of what we teach. We talk about pain and stress physiology, helping people understand why it is that stress worsens pain and what you can do to influence that. I'm going to elaborate on that in just a little bit. We talk about sleep hygiene, things that we can do to improve the quality of sleep, help people identify stressors, different triggers that can exacerbate pain, what they can do about those, different stress management strategies, which I'm also going to talk about in a little bit, communication planning or communication skills development, because even if we teach people how they can manage their own pain, as human beings, we don't live in a vacuum, right? We live in societies, we live with family members, we have friends, and it's important to be able to learn how to advocate for our needs, how to communicate with other people when we're living with a pain condition. And then we teach people flare management planning. The one thing that I guarantee folks when they take our classes, what I say in the first class is, if you do everything like I teach you to do, I can guarantee you that you're still going to have pain, right? Because that's the reality of the situation. That's the reality of chronic pain. But how do we manage those flares in the pain? Since we know that there's going to be something that appears, how can we manage those? And that's part of what we talk about in these classes as well. But what I'm going to talk to you guys about for the second half of this presentation is I want to go over what some of these non-pharmacologic approaches to pain management are. Right? That was the title of the presentation. That's probably what brought a lot of you guys out here tonight. And I'm going to go over just a couple of ones that patients have told me have been the most pivotal for them, that have helped them the most in being able to better understand and better relate to their environment. I'm not going to go into these in the detail that we usually do in the class, just because that would take too long. These classes are 9 weeks long. We usually go over one topic over an hour and a half or 2 hours. So I'm just going to give you guys a quick overview of some of these different areas, and hopefully you can take some of these home with you and use them yourselves. So one thing that's important to recognize is the relationship between stress and pain. One thing that we know about life is that life is inherently stressful. We can't give people stressectomies and just make stress go away. It's just a part of life, right? It would be lovely if we could do that. But one of the things that we also know is that stress will directly influence the pain that a person has, right? How many of you have had, even if you don't have a chronic pain condition, think about if you've just had a regular run-of-the-mill tension headache. How many of you have experienced something where as you have some sort of pain, the more stress you get under, the worse that pain gets? Only 4 of you? Wow, that's surprising. Because the reality is that happens to all of us, right? Let's say that I wake up in the morning. I need to go to work. I'm running just a little bit late. I go to my driveway. I start to pull my car out of the driveway and I've got a flat tire, right? If I've woken up in the morning with a headache, I see that flat tire, that headache's going to ratchet up just a little bit more, right? I take another car, I get to work, and I find out that somebody else is using the room that we usually use for rounds, and we have to move our whole team somewhere else. The headache's going to ratchet up just a little bit more. Right? Then I go to the outpatient clinic and I find out that they added 6 patients onto my schedule that day. Right? The headache's going to ratchet up to a little bit more. Now, the headache pain isn't getting worse because I'm imagining it getting worse. It's not a psychological process, but it's actually based on physiological changes within my body. Right? And I'm going to walk you through what those changes are. So in order to understand this relationship between stress and pain, we have to understand a little bit about how our body's nervous system works. So our nervous system is divided up into 2 broad categories, central and peripheral nervous system. Peripheral is further divided up into somatic and autonomic. Autonomic nervous system is automatic. We don't have to do anything to control the autonomic nervous system. This is the part of the nervous system that does things like regulate our heartbeat, our breathing, things along those lines. So the autonomic nervous system is further divided into 2 categories, the sympathetic and parasympathetic nervous system. Now I'm going to talk about those a little bit more. The sympathetic and parasympathetic nervous system, they're responsible for our responses to stress, right? Whenever we get exposed to a stressor, the sympathetic nervous system activates, and it causes a whole host of changes. All these things that I've listed here on this slide are the things that happen when the sympathetic nervous system activates. Our heart rate increases, blood pressure increases, blood vessels constrict. As your blood vessels constrict, we feel that as our hands and feet getting colder, right? GI processes slow down. We have more blood flow to our heart and lungs, muscle tension increases, stress hormones get released in the body. A whole cascade of changes happens when we get exposed to stress and the sympathetic nervous system activates. When the stressor is gone, when the brain detects that there's no longer a stressor present, another part of the nervous system called the parasympathetic nervous system activates, and it brings the body right back down to normal, right? Now again, this is an automatic process in your body. You don't have to do anything to make the sympathetic nervous system turn on and the parasympathetic turn on as well. It happens by itself. You know, all of you have felt this before. Think about if you're driving a car in traffic and all of a sudden somebody cuts you off, right? Immediately you tighten your grip on the wheel, you hold your breath, you feel your heart beating 1,000,000 miles a minute, you may even get a little bit of sweat on your brow, but as soon as you realize you're a safe distance from that car in front of you, you feel your body calm right back down, right? So what you felt when the car cut you off was that sympathetic nervous system activating to help you deal with the stressor, and what you felt when you realized that you were a safe distance away was a parasympathetic nervous system bringing a calm back to the body, right? And if this sounds familiar to you, you may remember it from high school as being called the fight or flight response within the body, right? That it helps you learn, it helps your body deal with stress. Now, why am I going on and on about this? Well, look at some of the things that happen when the sympathetic nervous system gets activated. You know, increase in muscle tension. If a person's got pain, right? Think if I've got low back pain, and if the muscles in my body tighten up, what effect is that going to have on the pain that I have in that part of my body? It's going to worsen it, right? And so this is one of the reasons why, it's not the only reason why, but it's one of the reasons, one of the mechanisms why stress can make pain worse, is through this activity within the body's nervous system, right? But what's also important to recognize is that this type of nervous system activation occurs in the context of any type of stress, right? We may see a difference between Doberman foaming at the mouth, coming in the room and growling, and having an argument with a significant other. Right? We see those two things as being qualitatively different. But to the body, stress is stress. And it's still going to cause the sympathetic activation, be it the dog or the argument with our significant other. The magnitude of the response will differ depending on the nature of the stressor, but we still get the sympathetic activation when we get exposed to any type of stress. And if we have a chronic pain condition, then that's going to lead to a worsening of that chronic pain condition. So if what I'm saying is true, and it is true, because I wouldn't lie to you, even though I lied to you about the cooking part earlier, pain is a physical stressor. So it's going to cause activation of the sympathetic nervous system. That sympathetic nervous system is going to cause those different changes in the body, which can turn around and feed back into the pain, right? So the pain can essentially feed off itself. And again, most of us have felt this before. You know, think about even with acute pain. If you've got a headache or you just cut your finger, the more you focus on that, the worse that pain starts to get, right? But pain is more than just a physical experience. We've got emotions that can come with pain as well, right? And again, if we're thinking about chronic pain, there may be anxiety, right? But that anxiety is an emotional stressor. And so it's going to feed back into the loop and exacerbate the pain as well. We may have anger, guilt, sadness, wide range of different emotions that will turn around and feed back into the pain again. But this is still just that one experience of pain. We've got lives that occur outside of pain. We've got stresses in our life. You know, we've got sleep issues that can develop, relationship issues, financial stressors. And let's assume that there's only one emotion associated with each of those. Those are going to be additional things that link into the cycle and feed back into the pain, right? So this vicious cycle is something that we very commonly see in pain. And it's something that makes a big difference in the pain basically getting out of control, right? And having a person feel like they're at their wit's end and that there's nothing that they can do to try to control this cycle. A lot of folks look at this and say, well, what's at the center of that is pain. Just get rid of that pain and we don't have to worry about this. And that's true, but again, we're talking about chronic pain that we don't have a cure for. So that's not really an option, just to try to get rid of that pain that's in the middle of this. So we have to learn how to break this cycle on either one of those sides. And those are going to be the two strategies I talked to you guys about today, is how we break these two cycles. So learning how to break the cycle on this side, when all of these stressors are going on, nervous system's activated, how can we stop this from feeding back into the physical pain? One of the ways that we can do this is through breathing exercises, relaxation training, right? a lot of times people have had exposure to different types of breathing exercises. And I'm not going to go through and do an experiential exercise with you and teach you how to do this, but I'm going to go over some of the basic components of what we need to do in breathing exercises for them to be effective. The first thing that we need to do is we need to make sure that we're breathing deeply, right? A lot of times when we get exposed to stress, we either start doing fairly shallow breathing or we hold our breath altogether, right? Think about when you've had pain or if you're bracing yourself before you get up to try to avoid pain. More often than not, you're probably holding your breath when you do that, right? And if there's already some nervous system activation that's occurring, the brain's going to see that you're holding your breath and it's going to brace itself more for more stress or more pain. So the first thing we want to do when we try to do these breathing exercises is start to do more deep breathing, right? Deep diaphragmatic breathing. So when we breathe air into our bodies, the air goes into our lungs, right? And our lungs are just like giant balloons. Well, not giant balloons. Our lungs are just like balloons. And they inflate when we bring air into the body, right? But think about a balloon. If I have a long balloon, like the kind that a clown uses to make swords and poodles, if I start blowing into that balloon, what part inflates first? The part close to my mouth or the far end of the balloon? Close to my mouth, right? It starts to get big right in front of my mouth, and I've just got this long thing of latex. But as I breathe into the balloon all the way, the entire balloon starts to expand. It's the same thing with our lungs. When we breathe in at first, we only inflate the upper registers of our lungs. But as we breathe in deeply, the entire lung starts to expand. Right? As our lungs expand, they don't start to poke out of our rib cage. They don't start to come up into our throat. But instead, they push on a dome-shaped muscle that kind of goes around, separates your chest cavity from your GI system, called the diaphragm. When your lungs expand, it pushes on this diaphragm, causing it to expand. And when we exhale, it contracts. So we see this in our bodies as our belly's rising and falling. But the air is never going into our GI system. We're just filling our lungs completely, causing this diaphragm to expand and contract. And so you may hear this being called diaphragmatic breathing. If you're a musician or a singer, you probably learn to do this diaphragmatic breathing so you can get more range in your tone, right? This is actually more of our natural way of breathing. If you look at a dog or a cat or a child when they're asleep, it's the belly that rises and falls, not the chest, right? So what we're trying to do with the breathing is to try to bring back that natural pattern of breath. So we need the breathing to be deep. We need it to be slow, right? That's the second piece of what we need. And again, oftentimes people are holding their breath or breathing very rapidly. I usually recommend that people breathe into a count of 5, hold it for a second, exhale to a count of 5, and wait another second before taking another breath. Now, this doesn't mean you breathe in and hold your breath for 5 seconds. I always see people go, and then they hold their breath for 5 seconds. The inhalation should span 5 seconds, right? And that pause should be a natural pause because you feel like I can't get any more breath in. And then you exhale. And that last pause before you take another breath should also feel very natural, like I can't get any more air out. And it should be a very fluid, wave-like pattern to the breathing, not something jagged. Those are the first two components of breathing. And unfortunately, that's oftentimes where I hear people leave off with breathing exercises. They say, go do some long, deep breaths, count to 10, get out of here, and you'll feel better, right? But there's one critical component that without it, the breathing exercises aren't going to be effective, and that's mind control, controlling where your brain goes. You know, if you're stuck in one of these cycles, right, and if your brain, you say, you know, I'm going to try to do that breathing to break this loop over here. You're trying to do the breathing, but your brain keeps thinking about your pain, or your brain keeps thinking about the relationship stressors. Well, those thoughts are stressors, and so they're going to activate the body's nervous system. So even though you're trying to calm this nervous system reactivity down through your breathing, your thought processes are reactivating it. And so it's kind of like if we have a fire and we're pouring water from one end with the breathing exercises, but gasoline from the other, right? It's going to cancel each other out. But even worse, you'll walk away from the breathing exercises saying, oh, I tried those and those don't work. When it's not necessarily that they don't work, but you weren't able to use them to their fullest benefit because of that mind control piece being absent. So why do breathing exercises work? They work on two levels. One reason why is because it triggers parasympathetic nervous system activity. Right? I mentioned that the nervous system, the sympathetic and parasympathetic nervous system work automatically, but as you start to regulate your breathing, you're sending cues to your brain that there's no stressor here. We don't need to have this activation. And so that triggers activation of the body's parasympathetic nervous system, which helps return the body back down to a calm. So as you regulate your breathing, parasympathetic nervous system kicks in, heart rate slows down, blood vessels expand, GI processes resume, any stress hormones that get released stop getting released in the body, and the body slowly gets back to a calmer state. So it's not just a psychological trick that you're trying to do. You're actually creating physiological changes in your body. The second reason why it works is more simple than that, which is the element of distraction, right? Your mind can only pay attention to so many things at once. Your mind is somewhat like a flashlight or a spotlight. If I turn all the lights off in this room and I take a flashlight and I shine it on these books, the only thing that we're going to see is these books, because that's what I'm focusing the beam of light on. If I then move the beam of light to the sign on the wall, we no longer see the books. The only thing that we see is that sign on the wall. It's not because the books don't exist anymore. They still exist, but we're just not focusing that beam of light there. Well, it's the same thing with our minds. As we control where our minds go, as we're focusing on relaxing the body, it's not that our stressors or our pain have disappeared. They still exist, but we're giving our bodies a reprieve so that we can stop this feedback loop and stop that overactivity of the body's nervous system. Right? So I mentioned that we can break this on two sides, and I realize I only have very few minutes left. So I'm going to go through the second tool that I want to talk to you guys about, which is how to break it on this other side. When we have all these different stressors going on, there's something that mediates our emotional and physical responses, which is our cognitive processes, our thought processes, right? So our thought processes guide pretty much everything that we do in our lives, right? So we can look at most situations in our life and the way we respond to things in a very linear fashion. There's some sort of situation or event that occurs. We have some sort of interpretation of that situation or event, our thought processes, our cognitions, which lead to our emotional, physical, and behavioral consequences, right? So for example, situation may be that a person wins the lottery, right? They interpret this as, oh, this is wonderful. There's so many people I can help. I already had enough money. I'm a CEO of a large company, but this is great. I can help so many people. I'm so fortunate. So emotionally, they'll be feeling happy. Behaviorally, they may be pretty engaged, smiling. And physiologically, once the initial excitement of the lottery is worn off, they're not going to have a lot of that sympathetic activation, right? Their body's going to be in a calmer state. Well, let's say that we've got another person who's also a very rich CEO of a company who's also won the lottery. They interpret that situation as, well, this is terrible, right? I didn't want to win the lottery. I didn't even get that ticket. Somebody gave that to me as a gift. I just turned it in, found out I won, and now the state's going to make me take all this money now. I already planned how I was going to do my taxes, and this just throws a loop in my plans. This is terrible. This is the worst thing that could possibly happen to me. I should fire that employee who gave me the ticket, right? Emotionally, that person's going to be upset, right? They're going to be angry. Behaviorally, they'll probably snap at other people. And physiologically, they're going to have a high level of that sympathetic activation, right? And so if they have a chronic pain condition, that's going to worsen their chronic pain condition. But let's look at this. Both of these people had the exact same situation, right? They're both well-to-do people who won the lottery, but they had dramatically different outcomes. Why is that? It's not a trick question. The answer is in the middle. It's the interpretation, right? And that's the crux of what we call a cognitive behavioral model, that it's our thought processes, how we interpret situations around us, that play a big role in dictating how we feel emotionally, what's going on physically within the body as far as that sympathetic activation, and the behaviors that we engage in. Now, the challenge with this, though, is oftentimes we act as if we're stimulus response creatures, right? We tend to not pay as much attention to the interpretation part, and there's a good reason for that. Oftentimes, our interpretations are automatic. We don't stop and think about things before we respond to them. We have these very quick and automatic thoughts and responses to things. So if we were to ask those two people who won the lottery, hey, person number one, why are you in such a great mood? Oh, it's because I won the lottery. You ask the second person, hey, why are you in such a bad mood? Because I won the stupid lottery. It's not the situation, it's the interpretation. But people don't say, oh, it's because of the way I'm interpreting the situation of winning the lottery, right? That's not how we talk, that's not how we think. These thoughts occur in the background. But these thoughts are really pivotal in influencing what our outcomes are. So let's take an example of pain. Let's say that somebody wakes up in the morning with a high level of pain. If they think to themselves, this is never going to end, right? Life is terrible, the whole day is ruined. Well, naturally, they're going to have a high level of emotional distress. They may have sadness, they may have anxiety, they may have anger. Behaviorally, they may end up overextending themselves, doing things that aren't too healthy for their body. And then they'll have activation of their body's sympathetic nervous system. That stress response will kick in, which will cause increase in pain, right? Feedback into that pain, which will make the thoughts more polarized, which makes the behaviors more polarized, feeds back into the cycle, and it becomes that vicious cycle. right? So what we do in paying attention to the cognitive processes, the way we break this cycle is targeting those interpretations. And it's not something as simple as just, turn that negative into something positive, because there are a lot of things where we don't have a positive, right? But what we find is that it's not necessarily negative versus positive that influences our outcomes as much as the accuracy of the thoughts that we have. Particularly when we're stuck in a place, when we're in a rut, where there's some negative emotions that are occurring, oftentimes we have a lot of exaggerated thoughts that aren't quite true representations of what's going on, or we have thoughts that aren't very helpful. So one of the ways that we help patients learn to break some of these cycles is by targeting these thoughts, assessing them. Are these thoughts helpful? Are they accurate, right? So this individual, there's nothing I can do to control this pain, right? If a person asks themselves, is this true? Is this accurate? Is it helpful? Well, first of all, to tell yourself there's nothing I can do to control this, that's not a helpful thought, right? That's just going to engender the sense of helplessness and hopelessness. But the reality is it's also not accurate, right? We may not have a way to fix pain, but that doesn't mean that there are not things that a person can do, for example, like the breathing exercises, to help influence what's going on with that pain. So that thought's not accurate nor helpful. Life is terrible. Is that accurate? Well, at that particular moment, for that particular person, it may very well be accurate, right? But is it helpful to keep on thinking that? Not necessarily. And then nothing will get done today, right? That's neither helpful nor accurate because we don't know what the day looks like. It could be that you woke up with pain just because of the way you slept for the last 30 minutes, but after you get up and move around, you actually feel fine. So helping people recognize the unhelpful and inaccurate nature of the thoughts and modifying the thoughts into something that is more accurate and helpful, but that stays close to the original thought that was first there. Right? So for example, if a person's thinking there's nothing I can do to control this, the day is ruined, life is terrible, if you tell them, oh, but look, the flowers are in bloom and it's a pretty day outside. Well, that's great, right? It's a pretty image to have, but when you're stuck in that pain rut, that's not going to do anything to help pull you out of that, right? So you need to make sure that the way that you modify the thoughts is very close to what that original thought is in the person's mind. So the way you'd modify it, there's nothing I can do to control this, replacing that thought with, no, I can practice self-management skills. Life may feel terrible now, but I know this flare will end. I don't know what the rest of the day will look like, but I'll make the most of it by pacing, right? If a person still wakes up with pain in the morning, but they're able to get to a point where they have these different set of automatic thoughts, it doesn't mean that their pain goes away. It doesn't mean that they don't have the affective response, but the extent of the emotions will be less. They may not feel as sad, as angry, as anxious. There's a much better likelihood that these thoughts are going to lead to healthier behaviors, right? Pacing themselves, appropriately regulating their activities, and it's going to not cause that activation of the body's nervous system, right? Which is going to stop that loop from feeding back into itself. Right? But doing this is extremely challenging. It's so easy to present this as, oh, just change your thoughts, but it doesn't happen that way, right? Our thought processes didn't occur just when we started to have a pain condition. Our thought process had been shaped by all our experiences over the course of our lives, right? The way that we perceive the world, the way that we perceive our role in the world gets shaped early on by messages that we get from teachers, from kids, from spouses as we get older, and it constantly gets reinforced over the course of time. And again, I mentioned that our thoughts are automatic. So getting in touch with these thoughts that are happening oftentimes in our subconscious is a very difficult thing to do. And once we do finally get in touch with them and are able to identify what the thoughts are, having to try to change these thoughts that have been influenced by these deep-rooted aspects of our life, it's not easy to do. And so it takes a bit of work, a lot of time, to be able to learn how to modify these thought processes. And that's part of what we do, for example, in cognitive behavioral therapies, is we work with people to help them learn more about some of the unhelpful, inaccurate thought processes they may be experiencing in relation to a specific situation and what they can do to modify those. Usually what happens when people do this, it's not that all of a sudden they have 6 sessions of cognitive behavioral work with somebody and then all of a sudden they wake up and they feel perfect. Usually what happens is they find themselves in another situation with pain and they go through the same old thing that they usually do and they get stuck in that same cycle. After a number of times of doing that, they're like, no, wait a second, I'm supposed to think something else, right? And they do that after the fact and they walk through the situation and say, okay, this is probably how I could have thought about that. I'll try to remember that next time. But they don't remember it next time, so they have a number of times where they keep doing it after the fact. But eventually, they'll get to a point where they have that pain, and then they'll say, oh, wait a second, I'm supposed to think something differently now. And then slowly, that's when we start to have these automatic thoughts slowly start to come in. right? And while that may sound cumbersome and it may sound like, does that really happen? It really does happen, but it takes a lot of practice on the person's part to be able to catch themselves and to be able to make those different changes. But when it starts to become the most reinforced is with the outcomes. Because as people start to have healthier outcomes, then that starts to reinforce that behavior of continuing to have the more accurate, more helpful thoughts. And these types of cognitive behavioral strategies, they're not just for pain, but they're oftentimes used for depression, for anxiety, for anger management, for chemical dependency treatment. These have had a wide range of success in helping people learn how to manage these different types of stressors. Right? But we're pretty much at the 10-minute mark. Do these approaches really work? I'm not going to go through all the different literature that's out there. I'm not going to go through all our different studies. I can just tell you that we've done studies at Stanford that have looked at these approaches and seeing what their benefit is for our patients. There's a lot of literature that's been done that looks at these things, and they absolutely do work. We find that people's affective distress, things like depression, anxiety, start to decrease. People's involvement in their life increases. Their sense of control over their pain starts to increase. We haven't cured them of their pain, but their sense of control is improved because they know more about what are the different things that can trigger their pain, and more importantly, what can they do to manage those different factors, right? So if these are some things that you may be interested in, or you know somebody who may want to avail themselves of learning more of these different non-pharmacological approaches that we just kind of briefly went over, the best way to do it is through our pain management center. There are a lot of other pain centers throughout the area. I'm a little bit biased to ours. But all you have to do is just have your primary care provider send a referral over to our pain center. What we usually do when people come to our center is oftentimes we have what we call a multidisciplinary evaluation. And this is where at the first visit we don't assume care, we don't write medications or things along those lines, but you meet with the pain physician who will first do that medical optimization piece, making sure that there really was no stone that was left unturned, that there's no other diagnostics that need to be done. And then that can trigger the evaluation with the psychologist that looks at all the other behavioral factors or lifestyle factors, and evaluation with the physical therapist where we look at the physical reconditioning aspects. After all these folks have evaluated you, we have a team conference where the physician, physical therapist, psychologist, and all the other clinicians in the clinic on that day sit down and talk about the case to try to figure out what's the most appropriate trajectory, what's going to be the things that helps this person manage their pain condition as best as possible. In some cases, it may involve some medical treatment, some physical therapy, some of the psychological pieces. In other cases, it may be that, this person's really done a good job exhausting the medical factors. They're optimized here, but they really haven't done much of the physical or the behavioral. Let's focus more there. And then you get invited for a return visit where they walk you through what the treatment program is. Okay? But that's one of the most effective ways for us to be able to see if these types of classes that we have are effective for you, and if not, what would be most helpful for you. Okay? So with that, I'll open it up for questions. So the question is, beyond the things I mentioned of the physical therapy, psychological intervention, the medical aspect, what role do some of the complementary approaches play, such as acupuncture, yoga, things along those lines? So those are part of some of the services that we offer in our clinic. We actually offer medical acupuncture in our clinic. We actually oftentimes send people to the Center for Integrative Medicine. There are some services that we don't offer through our clinic that are available here at Stanford through the Center for Integrative Medicine, which is a lot of the things that you just mentioned. So even if we don't have that at our center, we'll refer people to those different spaces so that they can take advantage of those things as well. Yes, sir.
What is the connection between a hernia repair and getting some follow-on chronic pain?
So there can be a lot of different connections. So there can be some things related to nerve injuries when the surgery occurred. There can be muscle damage that occurred in that process. There's a wide range of different factors that can contribute to why chronic pain might develop from there. It would be impossible for me to guess what that cause might be, but there are a lot of different pathways of what may cause a hernia repair to turn into a chronic pain condition. So what kind of percentages of people go on from something like a hernia repair to go on and develop chronic pain? That's difficult to try to characterize because we don't know. A lot of the folks who don't go on to develop chronic pain never really hear from them again. Some folks who go on to develop chronic pain, they still don't report to a medical center. They just figure, well, this is just part of what I'll have to deal with. So I don't know of any specific figure that'll characterize how many people go on to develop that chronic pain. The biggest figure I have is just kind of the sense of how pervasive pain is within our general population. But I don't think there's really any good, reliable statistics that will best characterize that specific question of how many people with hernias may go on to develop pain. The question is there anybody that uses any other modalities such as things like hypnosis to help facilitate the process of the cognitive behavioral therapies? There is some self-hypnosis that's taught, but more often than not, if those are modalities that people are interested in, we may refer them to colleagues in the community who engage in some of those practices, although the extent of what we do is teaching some self-hypnosis. But very similar to the question about taking advantage of other resources, if we don't have them in our center, we refer people out to help take advantage of any of those things that we know that can be helpful for folks. Center for Integrative Medicine. So that's actually here in this same building. That has a wide range of different complementary alternative interventions. It has mindfulness, stress reduction classes. It has acupuncture, wide range of different things. So the question is, when somebody's doing the cognitive behavioral work, a lot of times a person may say, I'm saying the thoughts, and I can hear myself saying it, but I don't believe it. How do we help people make that leap? There's several different things. Sometimes it's repetition, because if you've been telling yourself something for a long time in your life, that's a part of reality. And so part of the cognitive behavioral work is changing some of your reality. And so it does feel different. It does feel unnatural. But part of what you do is you help look at the evidence that supports why something is accurate versus inaccurate, right? Well, this doesn't feel, I hear myself saying it, but I don't believe it. Well, why don't you believe it? And as a person starts going through the reasons why they don't believe it, you start to identify more of the cognitive distortions, more of the things that aren't accurate and aren't helpful, and you systematically go through and you help address some of those different things. And that's part of the reason why it takes a long time, because it's never just one thought that a person's trying to change. A second thing could be that there are more layers to it, that you're only working just on one superficial layer, but there are deeper rooted cognitive processes that need to get addressed. Do I know anything about neurostimulation? And so there's these devices that can get implanted in the body, spinal cord stimulators, where what they do is they stimulate a nerve, or they stimulate a part of your body to replace the pain signal that a person's experiencing. That's an example of a type of treatment modality that would fall into the medical optimization. There are certain pain conditions that may respond well to spinal cord stimulation. There are a lot of pain conditions that would not respond well. And so part of the medical workup is looking to see, is this a type of treatment modality that is appropriate for somebody? For example, I think it was Jerry Lewis had a spinal cord stimulator implanted, and he spoke on and on about it, the guy who used to do the Labor Day telethons. But then there are some folks where it's either not indicated or it's not as helpful. So just like many other treatment modalities, it can be helpful for the right person if it works. Have we had a lot of luck with fibromyalgia? We have had luck with fibromyalgia, and the things that we focus on the most are movement and stress management, right? And what we find, though, is that the biggest limiting factor, whether it's fibromyalgia or any kind of a health condition that a person has, the biggest limiting factor is the person themselves, right? So you know that old saying, you can lead a horse to water, but you can't make it drink, right? So if a person is motivated to do these things, because the behavioral stuff, it seems so simple and it seems so easy, but it's much more difficult when you're actually doing it. And knowing and doing are two different things. So you can amass the knowledge, but that doesn't mean that you're actually doing those things. So whether it's fibromyalgia or if it's complex regional pain syndrome or any type of a pain condition, what we find is that the success that we have depends most importantly on how much that person is working to put these things into practice. But with fibromyalgia, absolutely. When we help get people moving, help them learn how to pace activities, because one of the things that often comes with fibromyalgia is high levels of fatigue. That becomes a limiting factor. But as we teach people how to pace, as we teach people how to do the cognitive restructuring that can sometimes undermine their best of intentions, get them more active, teach them ways of doing that, those things can help quite significantly. Is there a bias in terms of if somebody's overly negative versus overly positive in their responses to some of these different treatments? And the reality is I haven't necessarily seen something just related to positive versus negative. What we have seen is that, for example, if people have a high level of untreated or undertreated depression or other types of psychiatric issues going on, that can undermine their ability to do these things because the depression saps the motivation or the ability to do some of these things. And so in those cases, we'll oftentimes work at the same time, concurrently on the depression and the pain. We can't say, oh, go get your depression treated first, then we'll work on your pain, because the two things feed off each other. So doing concurrent management of the depression and the pain can help change some of those outcomes. So that more so than just positive versus negative. Yes, sir?
What is the relationship between the Pain Management Center and Stanford Hospital Pain Clinic, the one over in Redwood City?
So that is the pain clinic. So they're one and the same. So our Stanford Pain Medicine Division has an outpatient center in Redwood City, and then we have our inpatient program in the hospital and manage all the acute pain in the hospital as well. Yes, sir.
What happens when pain disrupts sleep, where it's breaking through sleep? Because you're describing it as a conscious activity, something that's happening, a very conscious activity. So you're sleeping, and then you wake up with jolts of pain. What's going on?
So that's part of just the pain condition itself. So part of, again, without getting into specifics of certain types of pain conditions, as we speak just generally about chronic pain, one of the things we know about chronic pain, so the question is, what do you do when you wake up with jolts? And that it's not a conscious process, but you're awakened when you're just doing nothing but sleeping, and it wakes you up. So one of the things we know about chronic pain is it doesn't necessarily follow any kind of a rhythm or pattern. It's just going to kind of do its own thing. We know certain factors that can influence pain, some of the things that I went over, like the different stressors, emotional states, but a lot of times the pain is still going to kind of have a life of its own. And so we can never teach a person to control pain 100%, but the goal is to manage as much of the parts of pain that are in a person's power to influence as possible. And so in the end, what you end up doing is hopefully decreasing the intensity, frequency, and duration of those types of pain flares. But we can't eliminate them altogether. So why might you get jolted up with pain in the middle of the night when you're not doing anything that's irritating that? It could be related to just the nature of the pain condition itself. That could be one factor. Another factor could be related to activities. It could be that you overdid it during the daytime, and so you're kind of paying for it, your body is paying for it at night. It could be that you underdid it with activities and that your body is becoming deconditioned. So a wide range of different things, but ultimately it can still just be the very nature of pain without any specific causal factor.
So what do you advise patients to do about the jolt? Because the jolt does create the adrenaline, with an alerting mechanism. So
Absolutely.
You're awake,
So-
really awake.
So when that happens, so think about that again, that's a false alarm. Okay, this jolted me awake, this condition's already been worked up, there's nothing sinister going on. So if we think, okay, my nervous system's activated, let me do what I can to try to calm this down. So for one thing, the self-talk, telling yourself, okay, this hurts, but this is part of my chronic pain condition, this isn't anything to be alarmed about. So that's doing some of that cognitive restructuring, telling yourself that. And as you do that, doing some of the behavioral things like the breathing exercises. As you control where your mind goes, as you calm your body down, you're triggering that parasympathetic activity, which unwinds that activation that occurred. So the question is, if pain's a very subjective thing, are we able to assess people whose pain is if people are more sensitive versus less sensitive? The reality is, in the case of chronic pain, one of the things that we actually try to get away from is pain ratings themselves. Because what we find is that pain ratings don't give us a lot of useful information. Again, in the case of chronic pain, because a person who's very sensitive may rate their pain extremely high. A person who's not very sensitive may rate their pain very low. But still, that overall rating doesn't carry as much data, right? Let's say that this person sitting in front of me and I both wake up in the morning. She says that she has a 7 out of 10 pain. I say I have a 7 out of 10 pain. If she says, well, with my 7 out of 10 pain, I'm going to wake up, I'm going to go to work, I'm going to do my usual activities, I'm going to go to the health library lecture tonight, but after that I'm not going to have dinner with my friend because a 7 out of 10 is a little bit irritating. But if I wake up with a 7 out of 10 and I say, I'm not getting out of bed today, right? I'm going to cancel my appointments, I'm going to cancel the health library lecture, all of a sudden that pain intensity or that pain sensitivity lost a lot of its value because what's more important is the functioning. And what is a person able to do with whatever their level of pain is. And that doesn't mean that we need to turn into being insensitive and not care about that, but focus more on that quality of life piece. Does that make sense to you? Yes, sir.
Quick question.
Sure.
How is that surgical, I think it's like a surgical pump as far as what type of medication I guess would actually be implanted in the pump and exactly the function of it as far as how you'd be able to use that?
So with the pump, that's another one of those implantable medical devices similar to a stimulator. And what happens is that there's a pump that's implanted in your body. The medication is delivered within the spinal column area itself. And what kind of medications, it depends on what the person's pain condition is and what the provider felt is the most appropriate medication to be there. So in a lot of respects, it's like oral medications that it depends on what the situation is. But that would again fall in the medical optimization piece that would get assessed in that initial medical evaluation. Yes, ma'am.
Is, in general, medical insurance is sympathetic to the cost of reimbursed for the cost of pain?
So for a lot of the different things that I mentioned in my presentation, a lot of medical insurances do cover the cost of some of these different things. For a lot of some of the complementary medicine things, not so much. Like, for example, mindfulness-based stress reduction classes, they can be extremely helpful, extremely beneficial. I personally think that everybody on the face of the planet would benefit from taking one of these classes, but I haven't seen an insurance company that covers those before, right? For some of the things, insurance is helpful. For some of them, not so much so. But for doing things like the cognitive behavioral work, the pain coping skills development, things along those lines, yes, a lot of times those things are covered under insurance depending on a person's policy. Yes?
What about Medicare?
Same thing with Medicare. We have a large volume of Medicare patients within our clinic, take our classes, do some of the individual sessions, things along those lines. Absolutely. All right. Yes, sir.
Where are your classes actually presented?
In Redwood City. So we have an outpatient center in Redwood City on Broadway, yes, sir. So the question is, when people are trying to learn how to do the mindful breathing, they may get stressed in having to remember the count. Oh, I have to count to 5, or the breath has to be this long. How does that get addressed? The goal of this is stress reduction. And if we're doing stress induction, we're doing the exact opposite. And so I see that actually quite often. I tell people you need to have your diaphragmatic breathing, your belly should move. So people look down, they're using their abdominal muscles to make their belly move, which isn't diaphragmatic breathing. That's just using your muscles to make it move. They're trying to count, they get all tense and tight. And so we'll comment on that the goal of this is to let this be a passive process. If you can't, don't worry about the count if you're starting to get stressed out about that. Let's just try to regulate the breathing. And so we try to meet people where they are to try to help them get to a point where they can be successful with it. All right. Well, thank you all very much for coming tonight. I appreciate it.